everyone. Thank you for listening to my talk. My name is Bob Resta, and the title of my talk is What Was, What Is, What If? Trends and Predictions in Assessing the Effectiveness of Genetic Counseling. I have been contemplating the question about how to best measure the effectiveness of genetic counseling for many years and from many angles. I have been a practicing genetic counselor for 37 years. I was the second editor-in-chief of the Journal of Genetic Counseling. I was part of the committee that crafted the 2005 definition of genetic counseling. I've been a member of the editorial board of the American Journal of Medical Genetics for more than 20 years. I have co-authored a genetic counseling textbook. I have authored several chapters in other books and many peer-reviewed articles. I have blogged extensively about genetic counseling on the DNA Exchange for more than 10 years. So, what do I think is the best way to assess the effectiveness of genetic counseling after all this time and experience? Well, sorry to say, I don't have a very good answer, or at least I can't make my mind up. But I'd like to take you on a historical journey through the story of measuring the effectiveness of genetic counseling. I break my story up into 3 phases, and I admit these are somewhat arbitrary, but it's a good framework for understanding how genetic counseling has evolved over the years. So phase 1 occupies roughly the last half of the 20th century, and during that time, genetic counseling was primarily concerned with reproductive outcomes. And then phase 2 begins in November of 1996, and you'll see why I've chosen that particular date a little bit later in the talk. And that phase 2, ends for all intents and purposes yesterday. And then phase 3, well, that starts tomorrow and ends, well, your guess is as good as mine. But I will give you my best guesses about what the future will hold and recognize that probably most of my predictions will be wrong. Unless you are James Joyce, all stories have a beginning. And I've chosen August, really, of 1947 as the starting point. And that's when Sheldon Reed famously described or coined the term genetic counseling, which he viewed as a kind of genetic social work. Now, I know that's not really a definition, it's more of a description, but that is a starting point and a good place to begin our story. It's also, by the way, the earliest formal acknowledgement of the importance of the psychosocial aspect of genetic counseling. I've broken up phase 1 into 2 parts, 1A and 1B, and phase 1A I describe as occurring really between 1947 and roughly 1980. And formal genetic counseling during this period was practiced primarily within the context of medical genetics by physicians and PhDs. And although everyone likes to say that the end of World War II saw the end of eugenics, in fact, it's pretty clear from the historical record that eugenic influences on medical genetics persisted for several decades after World War II. And during this time, if you look carefully at the literature, the implicit and explicit goal of genetic counseling was to improve the genetic health of the population, primarily through reproductive measures. And here you see a graphic of the biography or autobiography of the great Jim Neal, physician to the gene pool. He was taking care of the population. I've chosen here 2 quotes to illustrate the focus of genetic counseling during phase 1A. These by 2 prominent geneticists, and I'll leave it to you to read these, but I think they communicate clearly what the goals of genetic counseling are, and these are just one of many quotes that one could have chosen to illustrate this point. The earliest study I could find in the English language literature that reviewed the success of genetic counseling was by Cedric Carter, one of the seminal medical geneticists in the UK, and in his paper published in the Proceedings of the 3rd International Conference on Human Genetics, he looked at genetic counseling at the Hospital for Sick Children in London, and what he found was that 2/3 of high-risk families were deterred from further pregnancies, and in low-risk families, 75% went on to have additional pregnancies. So he felt he was successful in encouraging and discouraging pregnancies accordingly. In 1979, Jerry Evers Kybooms and Herman Vandenberg published a review article that looked at 22 studies that attempted to assess the effectiveness of genetic counseling that were published between 1971 and 1977. And in their review, they focused on three areas: understanding of the disease and the recurrence risk, decisions concerning further pregnancies or other alternatives, or changes in family planning composition after genetic counseling. After reviewing this literature, the authors came to several conclusions, two of which I will highlight here by quoting directly from the article. The proportion of affected children born after genetic counseling corresponded more or less to the expected proportions. Genetic counseling, if adequately available to families at risk, allows them to plan in responsible freedom and can thus be a powerful tool in the fight against the burden genetic diseases impose on individuals and society. So clearly here, after looking at the literature, the focus of genetic counseling during this period is on eliminating genetic disease and helping society. Also during this time that amniocentesis was introduced into clinical practice, and this quote below from The Lancet illustrates the general view of the role of amniocentesis in the delivery of medical genetics, that is, to reduce the burden of genetic disease. Goals of genetic counseling, as actually stated by professionals, were sometimes at odds with the goals that were reported in the literature. Some of you may be familiar with this particular slide here, or at least the content of this slide. I'm not going to read it to you, but it is the original definition of genetic counseling as established by the American Society of Human Genetics, and this definition stood for 30 years. And it's pretty clear that this does not address genetic counseling as a means of eliminating the burden of genetic disease on society. In fact, I think the content of this definition, while a bit wordy and clearly written by a committee, is actually quite modern in its content. Nonetheless, there is a disconnect here between the stated goals of genetic counseling and the goals in practice. Now, historically, we shift to what I'm calling Phase 1B, where genetic counseling is still primarily concerned about reproduction, but they've moved beyond improving population health and disease burden and looking at the anxiety engendered during reproduction by prenatal testing and genetic risk. And how well do patients remember things? And what are their concerns? All of a sudden, we're starting to focus on the patient rather than on society or on the whole planet or the population. And I use 1981 because that saw the publication of really a landmark study in genetic counseling, the first large-scale prospective study that I could find, and that was by Jim Sorensen and his group, who at the time were in Boston. And the publication was Reproductive Paths, Reproductive Futures, Genetic Counseling and Its Effectiveness. The Sorensen et al. Study is truly amazing when you consider it took place prior to the widespread availability of computers. The internet was not around, email hadn't even been thought up yet. And this study looked at 2,200 genetic counseling clients. They specifically used the word clients at 47 clinics in 25 states across the United States. The counseling was conducted by more than 200 different genetics professionals, including physicians, PhDs, master's level genetic counselors, nurses, social workers. And they administered surveys prior to genetic counseling, just after genetic counseling was conducted, a week after, and 6 months later. And to supplement this data, they conducted 190 structured interviews at 12 of the clinics. Researchers addressed three specific questions. What are the questions and concerns clients bring to counseling, and the degree to which genetic counseling addresses these client-defined needs? The effectiveness of genetic counseling in educating clients, and the impact of counseling on clients' reproductive intentions. As you might guess, there were many results in this study, and I will just highlight a few. When examining the assessment by the genetic counselor of what the client wanted, 75% of counselors correctly identified recurrence risk as important to the clients. 43% correctly identified prognosis as important to clients, and all other client concerns were correctly identified by less than 30% of counselors. In other words, we weren't doing a very good job of listening to what patients wanted and needed and then addressing those. Surprisingly, there was minimal impact on these percentages if the counselor had a master's in genetic counseling, a social worker, whatever, or years of experience. We were all equally bad. In terms of impact on reproduction, most clients didn't change their reproductive plans following genetic counseling. The clients most likely to change their plans were those who were uncertain prior to pregnancy, and they felt they were now more likely to have children. Also, the clients most likely to change their reproductive plans were also those who felt that the counselor addressed their primary concerns. So if we listen to them, they'll listen to us. As for the million-dollar question about how effective is genetic counseling, I quote directly from the Sorensen study. To the question, is genetic counseling effective? We would respond that there is no simple answer. Rather, the answer or answers are situationally bound and must be addressed in terms of understanding why counseling is sought, the objectives of its providers, what the service consists of, and how it impacts on its recipients. Sorensen further state, any overall assessment must point to the fact that counseling has been effective for many clients, but ineffective or irrelevant for an almost equal number of clients. It's a coin flip about how good we are. Our study revealed that, in general, while counselors do a fair job of discussing the medical questions clients bring to counseling, they do a poor job of discussing socio-medical issues and problems. For clients, these issues and concerns are neither trivial nor peripheral. They're more than just patients, they're people. Of course, I recognize that not all genetic counseling was about reproduction, and the shift towards other areas of genetic counseling, I think, expanded once DNA linkage studies for Huntington's disease became available in 1983. And finally, studies showed a shift from the focus on reproduction to decision-making about genetic testing for diagnostic purposes, risk perception, family dynamics, the role of family and social support, psychological stress, coping mechanisms, etc. And also during this time, the work of Seymour Kessler, among others, helped change the focus of genetic counseling from an educational model to a counseling model. A series of articles published in the early 1990s, I think, capture the change in the focus of genetic counseling quite well. And this is really an exchange of letters or brief articles between Ruth Chadwick and Angus Clark from the UK. Angus Clark suggested that success should be measured by workload audits as well as measures of satisfaction by patients and referring agencies, and not numbers of pregnancy terminations. It almost makes it sound like a latter-day eugenics when you do that. Whereas Chadwick counter-argued that public health can be an acceptable goal of genetic counseling, along with measures of satisfaction and autonomy. Chadwick further argued that a eugenic goal can be acceptable in genetic counseling as long as patients have the autonomy to just say no. That is, they can follow whatever reproductive path they choose, not what path we think they should choose. And Clark counter-argues, and actually Chadwick, I think, agrees with him on this point, that genetic counseling encompasses more than just prenatal diagnosis. It enhances understanding of the condition, screening for complications of genetic disease, social support, reducing stigma, and so on. Of course, what's important here is not who had a better argument, but rather that both authors agree that genetic counseling has more goals than worrying about influencing reproduction or the genetic health of the population. This graphic demonstrates graphically the expansion of the genetic counseling profession during this phase two and going on into the next phase. And I think it's important to point out that genetic counseling was no longer confined to medical genetics departments. We were working with obstetricians, epidemiologists, social workers, neurologists, oncologists, cardiologists, etc. And this really helped expand our focus and change our goals. We come to phase two, starting in November of 1996 and ending, as I say, yesterday. And during this time frame, we see a shift away from primarily reproductive counseling, an expansion into multiple medical specialties, as that previous graphic demonstrated. There are also new technologies and also new goals. There was also clearly deeper exploration of psychological aspects and patient experiences. Here is why I've chosen November 1996 as the starting point for phase two of my history of the effectiveness of genetic counseling. It was at this time that Myriad Genetic Laboratories in the United States launched their test called BRCA-analysis, which their marketing material at the time called the first full-length gene sequencing test for a major common disease for the oncology market, barely 2 years after the genes had been identified. And it was at this point that genetic counseling began to expand to common disorders and gave them larger populations to study. And looking at who undergoes testing, why they undergo testing, how do they manage their results both emotionally and from a healthcare standpoint. It was not all about BRCA that changed genetic counseling. The Human Genome Project was completed during this time frame, and this work ultimately led to the genomic testing that we have today. There was greater availability of genetic counseling and genetic testing for many conditions. There was a formal professional separation of genetic counselors in the US from medical geneticists, the establishment of the American Board of Genetic Counseling. Also, the Journal of Genetic Counseling debuted in 1992, and this gave genetic counselors and other researchers an outlet for research that focused on non-medical aspects of genetic counseling, looking at the psychological, emotional, ethical, and cultural aspects. Also, in 2005 and published in 2006 was a new definition of genetic counseling, of which I was a member of the task force. And so genetic counseling is now defined by genetic counselors. This is a big shift. You're all familiar with this definition. Genetic counseling is the process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. This process integrates the following: interpretation of family and medical histories to assess the chance of disease occurrence or recurrence, education about inheritance, testing, management, prevention, resources, and research, and counseling to promote informed choices and adaptation to the risk or condition. So no mention of the health of the population and very little about reproduction itself other than what's inherent in all of those aspects. We also see the introduction of new measures of effectiveness, and perhaps the most important one, or the first, was by Shoshana Shiloh from Israel, and in a publication in the American Journal of Medical Genetics in 1999, she used the concept of perceived personal control, and which is defined pretty much as the belief that one has at one's disposal a response that can influence the aversiveness of an event. Shiloh et al. Developed a relatively simple 9-item questionnaire, pictured here but difficult to read, which is the first formalized attempt to measure the effectiveness of genetic counseling as a psychological clinical intervention. Of course, there are other measures at this time for the effectiveness of genetic counseling that were being developed. For example, Marion McAllister's the Genetic Counseling Outcome Scale, which now has multiple different versions, but it was designed to measure decisional control, cognitive control, behavioral control, emotional regulation, and hope. Very different measures, of course, than reproduction and anxiety. During this time, practice models of genetic counseling were being developed, most notably by Bonnie Leroy and her co-authors at the University of Minnesota, uh, what they call the reciprocal engagement model, which is a practice model centered on the counselor-patient relationship and based on the premises that patients are resilient, that their decisions should be autonomous, emotionally centered, and cognitively informed, and in the best interest of the patient as articulated by the patient. And so this is, of course, not a way of evaluating genetic counseling, but it does provide a model about against which one could then evaluate genetic counseling. Did it meet these specific goals? Other outcome measures were introduced during phase 2. For example, family communication. How well is genetic information communicated within families? And how often do relatives act on that communication? And how does that communication play out against the family dynamic? Other outcomes looked in some studies include health behaviors. Does genetic counseling affect whether or not women will undergo risk-reducing surgery? Will they listen to recommendations that we provide? And this is very different than the disease prevention, if you will, of the phase 1, where it's actually trying to prevent the disorder and the person with the disorder rather than manifestations of the disease itself. And here we're not focusing on reproduction, but on patient behavior. How well do patients adapt to genetic disease? A genetic disease can really alter your daily life and how families interact and psychological management. And looking at how genetic counseling helps with adaptation is also another new goal of genetic counseling. Now we come to the future. We've zipped through 75 years of history, and now there's a future in front of us. So in this section, I'm going to discuss the challenges that we will be facing as a profession and the questions that we should be asking. I will say up front that if any of my predictions about the future turn out to be correct, most often it's going to be the result of a lucky guess. And whether my predictions are right or wrong, I've learned over the years that everybody gets mad at the prophets. But hopefully we'll stimulate some thinking, some discussion, and hopefully healthy disagreement. To some extent, the past can help predict, or at least better understand, the future. Past measures of the effectiveness of genetic counseling have reflected multiple factors. They've occurred within a specific historical and cultural context. They reflected the training, interests, sociocultural background, and biases of genetic counselors and researchers. They partially stemmed from advances in genetic testing and treatment for genetic conditions, which raised new possibilities for measuring effectiveness. Presumably, so will future measures of effectiveness reflect these factors. So what other factors might also affect the goals of genetic counseling over the next 10, 20, 30 years? Well, certainly the dropping cost of genetic testing will result in more people having tests and more healthy people having tests. And so they may have very different needs and wants than traditional genetics patients who were seeking a diagnosis for a specific condition. Also remember that geneticists are no longer the gatekeepers to genetic testing. About everybody can have a genetic test or can order a genetic test. And so we may more often be seeing patients after they've had their testing rather than before. And also direct-to-consumer genetic testing, even if it's not available in your neck of the woods, well, it will be eventually. And we'll be seeing a very different range of patients with a very different set of questions. Availability of safe legal abortion may not be a guarantee in the future, and countries that don't have it now may not get it in the future. This potentially could affect what patients are seeking from genetic counseling, especially in the context of prenatal testing. Also, we likely will see a very different patient demographic in the future as genetic testing becomes more widely available and as the demographic of populations change with migration. New Genetic tests in the future will raise questions that we don't even know to ask today. Think about the issues raised by genomic testing versus a karyotype. Or changes in social attitudes and ethics may occur. Think about now how expanded newborn screening is justified by minimizing the diagnostic odyssey and replacing the Wilson-Jungner criteria. Also, there will be greater global availability of genetic tests and genetic counselors outside of the westernized Anglophone world, and this will bring a very different cultural and worldview to genetic counseling. The widespread acceptance of non-invasive prenatal testing and expanded carrier screening, we do raise the concern about a eugenic aspect of genetic counseling once again. And the question one might ask, why has there been so little research about the utility of prenatal testing beyond pregnancy termination? I think if we can show there are other advantages to prenatal testing beyond termination, this might make it more ethically acceptable to people with disabilities, their families, their advocates, and society. As genetic testing becomes more complex, there will be a tendency to have genetic counseling focus more on technical information sharing rather than counseling itself. And yet, at its core, genetic counseling should always be counseling, not educating. Incorporating technology into the provision of genetic counseling, such as apps, artificial intelligence, chatbots, etc., may help and enhance genetic counseling. The worry is, will it replace it? Will commercial entities or hospital administrators decide it's much cheaper to have a chatbot than to have a live genetic counselor? And how does one evaluate a chatbot compared to a live genetic counselor? What goals does one use to show that one is better or inferior to the other? The last few years, I've noticed that there are studies that are being done that compare the uptake of genetic testing in 2 or more groups and use this as a measure of the effectiveness of genetic counseling. You can see these quotes below from 3 different articles and read them at your own speed. So we need to ask whether or not undergoing genetic testing is a goal of genetic counseling. Certainly, I know the value of genetic testing and it should be available to those who want it. However, should we be measuring the effectiveness of genetic counseling by test uptake? Or are we trying to make patients help them make emotional and cognitive sense of what's going on with their lives in relation to genetics? And should we be concerned, indeed, if they have a test or not, as long as we can help them adapt to their situation, whether or not they undergo testing? In assessing any study that looks at the effectiveness of genetic counseling, we should ask the questions of who, what, when, where, why. Who is measuring it? What are their underlying ethical values? When was a study done? Justifications in 1985 might not resonate in 2025. Where was the study done? Success in the US may not be the same as success in Brazil, the Philippines, or Saudi Arabia. Why was a study being done? Is it trying to show cost effectiveness, health outcomes? These are all very important questions to ask. We should, of course, show humility when we're assessing the effectiveness of genetic counseling for multiple reasons. First off, almost all genetic-related decisions are so complex and involve so many future uncertainties that it is impossible for patients or genetic counselors or anyone to know if someone is making a good decision. We should have humility in recognizing that genetic counseling involves many different activities, skills, goals, and clinical settings. No one measure of effectiveness can adequately cover them all. And whatever measures we use today for assessing the effectiveness of genetic counseling will one day by future generations be thought of as inappropriate, inadequate, and or ethically unquestionable. We are not perfect, and future generations will think we are even less perfect, but we need to keep on doing it with a critical self-awareness. I thank you for listening to my talk. I hope you find it stimulating. I hope you disagree with me, and I look forward to engaging you in discussion.